So I'll be talking about another aspect of treatment in the management of keratoconus. I have no financial interest to disclose. Now, we have heard about cross-linking, which arrests the progression. In the refractive correction, besides using contact lenses and doing customized refractive surgery combined with cross-linking, intracorneal ring segments are a good option. These are basically devices made of PMMA of varying arc length and thickness. These have positioning holes. The newer ones come with asymmetric thickness, thinner on one side and thicker on the other side. And they are in different cross-sectional shape from hexagonal to oval to triangular. The common products available with us are the INTACS-SK, the Kera ring, and the Ferrara ring. The INTACS and Kera rings are FDA approved. It works once it is inserted deep into the corneal stroma. It basically results in focal steepening at the site of implantation. The peripheral cornea is stretched, and this results in a central flattening. So if you look at this topography before and after INTACS implantation, a single segment was implanted, you can see the change in the corneal topography. And if you look at the pre and post topography, you can see the difference map, which shows you the significant amount of flattening. And notably, if you go in the pupillary area and look at the asymmetry between pre-op and post-op, you can see why the patient's visual acuity improved after the implantation of the intracorneal ring segments. How is it implanted? Commonly, we use the femtosecond laser, although earlier we used to use the manual technique as well. The femtosecond laser is more versatile, easier to perform. It creates channels which are uniform depth all across, and it is associated with lower long-term risk of complication, especially extrusion of the ring segment. This is how it looks post-operatively. You can see a single segment in the lower image and the double segment in the upper image. In patient selection, you can do it for mild to moderate keratoconus, for post-LASIK ectasia. If you're using the INTACS, I usually like to do it for a maximum K of less than 58 diopters, although the Kera ring and Ferrara ring, they are implanted in a smaller diameter area, so they can be used for steeper corneas. The minimum corneal thickness should be 400 microns at the site of implantation. There should not be any corneal scarring, because that can alter the outcome. And the patient should have realistic expectations from the surgery. This is a nice flowchart described in the paper by Rohit Shetty from Narayan Netralaya. So basically, how do you do your surgical planning? It depends on the location of the cone, whether it is central or it is displaced away from the center, the amount of superior-inferior asymmetry, what is the mean spherical equivalent, and what is the mean keratometry. So let's look at some examples. So this is a patient who has moderate keratoconus, and there is this decentered cone, and the superior-inferior asymmetry was not very high. So we went ahead with asymmetric rings. The superior ring was 250 microns in thickness. The inferior ring was 400 microns. And that's how it looked post-operatively. And you can see that there is significant reduction in the keratometry and the astigmatism as well. So from pre-operative, about 624, the patient's unaided vision improved to 612 and best corrected improved to 66. This is another case with asymmetric, the cone is displaced inferiorly, and it's the steep K is not very high. It's about 50 diopters. We went ahead with a single segment implantation in this case to support the cone inferiorly and lift it up. And in here you can see from pre-op 5/60 unaided, it improved to 618, and the best corrected visual acuity improved to 20/20. So in this case, a single segment helped improve the quality of vision. You can combine it with cross-linking to stabilize the keratoconus. You can further improve vision by giving a refractive correction using topography-guided PRK. You can even do a toric ICL implantation once the refraction is stable. And if there are any associated lens changes, you can think about doing a toric IOL implantation. This is a 30-year-old male patient with uncorrected visual acuity of 2200, best corrected of 2080. And he was not willing to wear contact lenses and wanted some form of refractive correction. So we went ahead, and this is his higher order aberration. You can see the total aberration was 1.41. The coma was about 1.09. So coma is the main reason why these people have deterioration in the quality of vision. So we went ahead, did a femtosecond laser-assisted INTACS SK 350 micron segment implanted at 400 micron depth. And post-INTACS is visual acuity improved to 20/30 best corrected. And you can see the change in the topography, and it explains to you why there is improvement in the vision. And especially if you look at the high order aberrations, you will find that his coma has reduced to 0.36 microns, which indicates why he was feeling better. Now we waited for 3 months, and once his refraction was stable and the topography was stable, we went ahead and did a topography guided PRK with accelerated cross-linking. And the maximum ablation was in the center was only 31 microns. And this is how it looked post-operatively. His visual acuity best corrected improved to 20/20 with just -1 with -0.75 cylinder. And if you look at the corneal topography, it looks almost normal. And if you look at the high order aberration, his coma has further reduced to only 0.14 microns. And that explains why the vision improved in this case. So this is the pre-op and this is the final post-op. Complications can happen with INTACS. You can get channel deposits over a period of time. These are whitish yellow deposits on the inner side of the ring. These are proteinaceous deposits along the channel. You see them more when you create the channels manually. And if you make the channel 360 degrees, then you can have these channels, the INTACS segments migrating towards each other, so you can have overriding of the implants. If you place your suture when you are doing 2 segments and you don't remove the suture, sometimes these loose sutures can lead to vascularization, and then the blood vessels find it easy to grow into the tract and can result in lipid keratopathy. And sometimes if the overlying cornea is not sufficient in thickness, the stromal tissue, then over a period of time, they can be progressive thinning, either due to disease progression or thinning of the stroma and result in extrusion of the implants. So basically, the tips for INTACS would be select the right case and the implant type, use femtosecond laser to perform the implantation. For additional procedures, I always prefer a sequential approach rather than doing everything simultaneously. If you want to perform cross-linking, you can do that either after a week or a month later. A stable refraction, usually I take it 1 to 3 months before I decide on what to do next. And the additional procedures like a topo-guided PRK or a phakic IOL can be done once the refraction is stable. Thank you. Thank you for your patient here.
Excellent, Rajesh. Well, very much in time and always very particular, specific. Great insight into the whole substance. Any of the ectasia cases that you've tried this? Anybody having ectasia and following that?
Yes, for post-LASIK ectasia, we have done single segment INTACS and they do quite well. In fact, it is recommended for post-LASIK ectasia if you see them, even in the early stage, if you do a single segment. And one thing that I have always found is I don't do a cross-linking before and do the INTACS later. I always recommend doing the INTACS first and then followed by cross-linking at a later date. Because once you make that cross-linking and the collagen becomes stiff, and if you put in your INTACS ring, you don't get the same kind of effect what you see when you do the INTACS first. And I don't like to do it simultaneously because whatever said and done, you are placing an implant within the cornea. And sometimes you can have an infiltrate after you have put the INTACS ring. So whether that's a sterile infiltrate from the cross-linking or whether that's an actual infective infiltrate, you won't be able to distinguish. So why mess it up? First do the INTACS, let it settle down, and then come back and do a cross-linking later. So that kind of seems logical and seems better.
Is it 6 weeks? Let it settle down is 6 weeks according
you can do it at, the keratoconus is not going to progress very rapidly. So you can do it even 6 weeks or 8 weeks, it doesn't matter. In fact, in certain of my patients where I've done INTACS first, some patients have not come back for their cross-linking. And I've seen a patient 10 years after I've done the INTACS and there has been no progression. So I don't know whether he was having progression before, but whether by placing an INTACS within the cornea, whether we are redistributing the forces which, lead to stabilization, I don't have an answer to that, but that would be something interesting to study and look at whether INTACS alone can slow down the progression of keratoconus.
KP, do you have any questions? Sujata?
No, sir. Like Rajesh, always, as usual, fantastic stuff. I was remembering 1.5 years before I went to Sri Lanka. So most of the patients those who underwent refractive procedure talking about Rajesh. Even most of the doctors are very much talking about Rajesh because that much of work even he has done even in Sri Lanka also. Really, we should appreciate him, sir.
Dr. Ravindra, you have something?
Yeah, wonderful presentation, Dr. Rajesh.
Thank you, sir.
Have you done manual, segments,
Yes,
surgery?
when I
versus-
started off, before we had the femtosecond laser, I was implanting my INTACs using the manual. And
What is the
it used to
difference
be-
between them?
Difference is that it used to be a little cumbersome because you had to do it under local anesthesia because of the amount of manipulations that you do. Once you give local anesthesia, then applying the suction ring, getting the centration used to be an issue. And even if you make the tracks, they used to be asymmetric at times. That means they are deeper at one end, shallower in the other end. And compared to that, the femtosecond laser, the channels are tighter, and you can really customize, because once you apply the vacuum, you can move around the fixation, and you can customize it much more.
Yeah. What is the tear film stability of these patients post INTACs? Are they better,
They are
same,
better.
or worse?
They are better than what they used to have earlier. And somehow if you are putting the intact segment, the intact segment acts like the new limbal point. So sometimes the refraction, you have to be very careful, because AR will give you all kind of readings, but that you can't use that reading for giving glasses for these patients. So they have to be refracted manually, and you have to really, but patients do appreciate, and they have good improvement in vision. But like I said, it's not something you can use for each and every patient. You have to, selectively, if you do it, you can get very good results.
Is the progression of the corneal, ectasia is any indication or contraindication or a special indication for INTACs? You covered that, but can you be more specific? Imagine, we have shifted a lot of our patients to contact lenses. They're so happy with modern contact lenses. The surgical intervention has come down a lot. So what's your comment on that, contact lenses
Absolutely.
versus
So
INTACs?
these are for the subset of patients who are not willing to wear a contact lens and are looking at something else. Otherwise, primarily, we try to fit every patient with a contact lens.
Okay. Good. Thank you.
We are not trigger happy gunmen, so we first try peaceful solutions, contact lens to start with.
The quality of vision, what they can get with the contact lens, I don't think anything else can give them.